individual versus just an overarching call type. And I'm not exactly 100% familiar with that. That may be needed to confirm with the sheriff, but at least with the jail, like I said, self-reported, multiple buckets ticked based on self-report and officer observation. So
could a checklist that was developed be easily integrated into your system, do you think, or is that?
I know it could be for the jail. That could be something that we could do in the jail for certain. I'd have to confirm that with the sheriff and see how that would work with our workflow.
Interesting.
And it doesn't sound like that would be simple for EMS to do. It sounds like that would be more complicated for you guys to add another code or be able to do multiple codes on a single patient. Is that accurate?
We can customize at least East Jefferson with using ESO. We can customize it as detailed as we want. It's all about the time dependent nature of the call, and if we have to expedite the patient to definitive care, then we could miss some of that. But I guess before we would do that, I'd really want to try to capture the end result of what exactly we're looking for data wise. So we're accurate on our input and you're receiving the data that's quantifiable at the end.
I echo exactly what Chief Rummel just said, as far as we can do the same thing in ERS. So so in the jail, they've got to be medically cleared first anyway, correct?
Not in all cases, no. Not necessarily. There are many bookings that we get that we're just flat out doing our medical screening at the time of booking.
Okay. I was thinking they had to be medically screened before they came to you, so the hospitals our link is going to be the hospital, but yeah, I think the same thing will work. We can just do some kind of form. So.
Okay, so it sounds like this topic, we have decided, yes, we want to continue on standardization. It's a worthwhile investment of all of our time. And that there's a subgroup between the hospital, sheriff, city police, EMS. It sort of works out exactly how we bring that about. Is that accurate? Anything else we want to add to that item? Okay, I'm going to, I want you to know I started recording, so everybody be good. The other thing that I wanted you to know is that I'm recording it because Jim Nobelli, who always has a lot to say about a lot of things, was the one who really got me thinking, okay, we should have this discussion now as soon as we can. And then he couldn't come because he's on vacation. So he's promised me he's going to sit and watch this with me, which also makes me think we should tell him happy holidays or something at the end. Okay, so going back to our...
Hey, Lori, sorry to butt in. So as I'm hearing all the feedback on this code sharing or code development, and I'm sure that the transport agencies in the room will nod, I think it would be useful to have somebody that's very fluent with EMS billing, because a lot of these codes, we may be creating a lot of duplication that may already exist at some point in the workflow for our platform that could be economized, or just not creating 2 and 3 similar steps, but just, hey, this is going to be close enough for us to not create too many auxiliary codes. I mean, we have the ability, like the other chief said, to add customized codes, but at some point there's going to be a trade-off between what the amount of time we're spending to decipher and interpret versus patient care versus at post-call deciphering what really happened on the call that is billable. And I don't mean to mean that money is the important driver, but trying to make a well-rounded decision on what the final list would be, I think would be prudent. So I don't know if there's somebody in this work group that has EMS billing background, but maybe the hospital might have a resource as well. I'm not sure. Maybe Chief Brummel or the other chiefs might have insight on that. Thank you.
If somebody has a name to throw out now, great. If not, we'll add that to the list of things in that smaller group that we want to get that person in on the conversation as well. No name? Okay.
I'm
So
sorry.
then- oh, go ahead.
We were chatting. This is Heather. She's going to be taking over for me when I go on family leave. So I just wanted to introduce her real quick. That'll be next month. I'll be off for a few weeks.
Okay. Hi, Heather. It's great to have you here. Heather, tell me your last name, or somebody tell me. Heather.
Friend.
Heather
Friend.
Thank you.
Yeah.
Okay. We'll make sure to get you on the list. All right. Moving on to our next bucket. So one of the reasons we're collecting this data is, of course, to get some baseline metrics. We need to address our HRSA requirements, which I'll be talking to you guys every 3 months about. We've done that this first quarter. I think I've touched base with every one of you just about. So you know what data is there. I don't think it's complicated data that we're trying to collect on that front. And then we know, because we are putting funding into the buckets of Recovery Cafe and South County harm reduction and a communication action plan that hopefully moves the needle some way, shape, or form on the topic of stigma. There is a question of, should we do a survey now? And I'm going to lob it over to Lisa to talk a little bit about that possibility.
Yes, and we touched base on this a little bit on at the meeting the other day, and we were trying to think, is there a way to do a survey? And we've thought of a couple different things. One is a survey, which I think a lot of you already participated in, the HRSA survey, a longer survey for the consortium members where we could really drill down on some of their impressions, what they think the main issues are, and also just some other baseline metrics. But then something shorter to be respectful of people's time, that we could get out to all the people that you work with. So a lot of your first responders, people in the community, to really get an idea of what's the baseline, and what's the baseline as far as what people see as the key issues, what's the baseline as far as things like, what do they feel are the, like, what's their impression, how comfortable are they with referring people to these services, what do people think the availability of services are, the main needs. Just a kind of a laundry list of both subjective and objective criteria that we could use as a baseline now and then measure moving forward. One of the things we raised at the meeting is what we don't want to do, and I'm seconding what was being just said, is we don't want to duplicate things and make things more difficult than they need to be. And there is some surveys that are going around out there. There's already a survey with the Syringe Exchange program that collects some of this data from the people that are in that program. Recovery Cafe already has a survey that they do with their the people that participate in their program. So we're just trying to get our arms around some feedback from all of you about one, what you think is out there, and two, do you think it is worthwhile and important to create a baseline for us to do a survey? And then what are your thoughts about what are the kind of key factors that we need to include in that? So I guess, do you think it's important for us to do one? And do you think there's some resources out there that we can already tap into?
Don't everybody.
And the idea, of course, is repeating the survey. If we do our own, we would be repeating the survey to see, again, are we moving the needle?
This is Mel. So just listening to that, you had a lot of qualitative, subjective type of data. You wanted to know what might be the barriers or what are people experiencing. So you might be able to get some of that more readily through key informant interviews or bringing together a group for a discussion that's led and then leads to qualitative information.
You think like focus groups rather than an online survey would be a better approach?
Yep, exactly.
So okay. If we did a focus group, Dave Fortino was like, I don't want to answer this question. If we did a focus group, do we think the sheriff's department, the police department would be open to the idea of us doing a focus group with folks that are on the police force or folks that are on the sheriff's team? Same with EMS, so that we're talking more to the people that are boots on the ground.
Yeah, and I think that kind of helps shape a little bit what my question was as well. Who would be the focus of this survey? I know that Chip did a survey not all that long ago, and there's various other surveys that I've helped facilitate here in the facility. So as far as our involvement staff-wise, I mean, I think the jail would be willing to include some of that. I don't know. I don't know. That's hard to say. I mean, I think that's just one slice of the pie when it comes to addressing what are the issues in the community. I mean, that's a very narrow focus. Maybe and that's speaking from the perspective of the jail.
Right.
Maybe our first responders have a different idea. They obviously see a lot more people in the community than we do. So I don't know. I guess I would say Chip probably has got a really good perspective on how well their survey went and how well, whether or not the feedback there was useful, and if there's routes we can take with that. I would say probably a community-based survey would maybe suit us well. But
Okay.
That's my input.
Thanks. Anybody else have thoughts on that topic? In the absence of that, maybe Lisa, John, and I will go back and sort of think about what we've heard here and come back to you with a proposed plan, which we can either shoot holes in or get behind, and we'll get it going. Because when we talk about getting a baseline, we're already a quarter into our grant, so I feel some bit of urgency to get something done, whatever it's going to be, so that we do have a baseline at the beginning of the grant and not halfway through the grant. Go ahead.
Mike, can I ask you a question? This might be backtracking a little bit, I'm not sure, but have we ever just have everybody fill out like a data dictionary, and police department fills out their definition of mental health and substance use disorder? We fill out ours. Everybody who's reporting data, just give us your definition of all the points, and we can even, I don't know, rate them on the scale of 1 to 5 of how close they all fit together or something. I feel like I feel like we're trying to solve a problem that we can't see sometimes.
Absolutely.
Have to take a step back, but have we done that before? I feel like we
Not
might.
my knowledge. Anybody else?
Well, we tried to do that a bit with these surveys or these phone calls I just did with people, and that was part of that PowerPoint, is how are people defining how people fall into these buckets. But I think it would be a really good idea to maybe think about what other definitions we need to have our arms around. I think that's a good idea, and to memorialize it more, have it, and then look at that side to side, because you could see if whoever's at the meeting, there was very different ways in which people were identifying who would go into each of these buckets, and some of them were multiple ways in even one agency. So yeah, I think that'd be a really good idea.
Okay, so on that one, we have an action item of setting up a calibration list that we all look at together. And Adam, is it okay if I come back to you and sort of think about what that looks like before we do up a draft of something that we bring back to folks?
I'd be happy to give input.
Great. So it sounds like the folks we need giving input then are EMS, police departments, sheriff department.
Yeah, I don't know if I'd be in a position to actually draft and I think it'd be better to have someone who's overseeing the whole consortium to have a better eagle-eye view of all the different components. I'm very tunnel vision into my.
Of course. So
it's
Lisa and I, but you'd be willing to. It's a good idea. I want to make sure we execute it in a way that really is what you were thinking as you offered it. Okay.
Absolutely.
Thank you. Okay, hopping back over to. So that was baseline metrics. One of the things that we really need to understand are where people are going in terms of discharge, referral, and process. And so that's one piece, discharge and referral. And then the other piece is where our service providers are doing this provider-prescriber integration. I think would be really useful for our community to understand if we've got people who go into MAT treatment to ensure that they're getting counseling, or that we're tracking somehow what our success rate at making that transition is. So there are two different aspects. And Lisa, I'm going to step back and let you talk a little bit.
Did you say you're going to let me talk? Is that what you said?
Yes.
Okay. Sorry, I couldn't hear you for a second. I think she might have just. So one of the challenges, and I think you heard it from somebody on the phone today too, is understanding what's happening with people. So we're talking about standardizing what buckets we put people in. We also would really love to be able to have a better look at where people are going. And not only where they're going, but where they were identified as needing to go, and what the barriers could have been for them not getting there, either people not knowing what resources existed or not having access to those resources, or what those issues are. And then just being able to paint that picture again to help us understand what the needs and gaps are, but also are we tracking things in a way that really describes that, where we can really get that information. And so, for example, for the Sheriff's Department, we could tell you all kinds of information currently about what those people looked like, what issues they were facing. It'd be great to know on the outside of that is what happened to that person? Did they go to jail? Did they get home? Were they referred to resources, et cetera? And even in the hospital to understand better, and I know Adam, I think Adam's working on this quite a bit, is when they show up at the ED, where do they go? I know East Jefferson Fire Rescue often takes them there and then goes back and gets them and takes them elsewhere, but just understanding where they go. And I know we've had conversations about the referrals from the ED, sometimes saying home, when really home could mean they got discharged to family to go to outpatient services. And so just trying to see in ways we can standardize or understand that whole process better from all these different angles, so we can just have a better picture of what the needs are and where the resources are. And again, this comes to this idea of being able to create a picture of both what resources exist and what resource gaps there are.
So as you guys listen to Lisa there, is there a sense of some first steps around that? Does it start with the hospital? So there is this thing that I saw, that the way teachers get their usually like third grader type students to participate is anytime somebody new said something, she would put a sticker on her face. And so the goal was to get as many people to start participating in the conversation. By the end of the call, she would have her face covered with stickers. So
are you trying to imply that firefighters are like third graders? Because I would say that we're probably a little below that.
But no, but I'm saying maybe if it worked for third graders, maybe it would work for genius. Or maybe I should do something more complicated, like, put pipe cleaners in my hair or something for every time somebody says something. Okay, so back to the question at hand. Where can we start on getting our arms around this discharge disposition?
Well, the first person that's probably going to see him after
Voucher first, and then
after EMS and police is the emergency department. They're going to be the ones that initially screen them after they get dropped off, because the EMS and the police are going to say, well, the person's intoxicated, but the ED is going to have a crisis worker that's going to determine whether the person's got a substance abuse problem that's more severe that needs to go to detox or needs to go to an outpatient facility after they sober up. So I think the ED is probably going to be the main person that's going to start that referral process.
So just to expand a little bit, because I know we have some new people on the phone too. One of the other things we want to think about is for people that don't go to the ED, that maybe needed food, housing, income assistance, job assistance, whatever the kind of socioeconomic help or social determinants of health kinds of things would need to. Is there a way to capture those for anyone that maybe doesn't have an immediate medical need, but we'd want to still find out what they would need to be successful.
So I know we have OLICAP on the phone. Seems like that'd be one place where there's probably an intake process.
Yeah, so we, depending on each of the programs and the grants, and what we're working on at the agency right now is a generalized intake, because the way it's been handled up until now is sort of by program or program specific. And so, you know, each of those programs makes us collect certain information on these individuals. But we do have a database system that we utilize, you know, to have information and have case notes and things like that. So, you know, what we want to ensure, you know, potentially is that the information, you know, we're collecting as we move forward with this generalized intake, that it does provide, you know, you all with, you know, some of the information, you know, that we're looking to have here, you know, to help us determine, you know, are we meeting these various needs throughout our community, and show the number of people, you know, that we're helping who have been recently discharged, or, you know, are trying to stay, you know, out of the system, or, you know, so learning from you all, you know, what information would be most helpful for you, and what of that do we already collect, and, you know, what can we do to help collect that, either at time of intake, or, you know, post surveys, you know, there's a couple of different options there. But, you know, for some of the programs, they're pretty intense about the level of data we collect, but it really revolves more around income and documentation, right? It's not necessarily about how the person is doing themselves. So, yeah.
Okay, so it sounds like one action there is we could get together with you with a list of what we really want to have, and then you would look through and see what you've got, and then where we could get what we hope to get from you that isn't among that. And then John, were you going to say something, and then I hopped over?
Yeah, I'm trying to get back to a little bit of what Pete said about it would be nice to know what happens to ED patients when they cycle through the system, and also it relates to this issue, which is, you know, what referrals do people have and what happens when they're discharged. And I think something that's been a struggle for us in terms of data collection is that, you know, a lot of times the ED will say discharge to home because the patient went home in their car, but the reality is that there was a referral for them to go to inpatient treatment, you know, in 2 days, or go to, you know, outpatient, you know, mental health treatment. Or so I guess I'm wondering if we could kind of kill two birds with one stone by looking at not just where someone was discharged to, but what referrals were made at the time that they were discharged, to see if they're getting hooked up to mental health services or substance use disorder services, or, you know, something like that. So I guess I'm wondering if we could take one more slice on the discharge from the emergency room. And Pete, I'd be curious to know if you feel like that's the information that you're kind of looking for too, in terms of, you know, you want to know what happens when you drop somebody off in the ED.
Yeah, that's appropriate. Again, we're just trying to collectively break the cycle, right? I mean, that's the intent.
Yes.
So,
well, and along with that, you know, so for those of us that are part of OCH, you know, we've been looking at a type of system where, you know, all of us could be tied into a database, a web-based thing that we would know, you know, and could be able to keep track on, you know, where some of these customers are at. Did they get these services? You know, where are they at in the referral process for those services? Like, are we waiting on housing? Are we waiting on, you know, what's going on there? And the barrier to all of that seems to be some of the privacy issues surrounding.
I'm literally on 2 different webinars in each ear.
That,
How's it going?
Dunya, I think you might be unmuted.
Dunya, you're unmuted.
Not great.
Let me see if I can.
It's so tough. It's insane.
There you go. And so, you know, that's sort of frustrating because, you know, as much as an attorney, right, I want to respect people's privacy to some degree, but, you know, when people are utilizing the services of a community and they, you know, are perpetually, especially some of our repeat folks, right, that we're really struggling with, you know, that's where I think, you know, we have to be willing to trust our various partners to be sensitive with that data. And so I think that's the difficulty, right, is the cross between those that are, you know, healthcare providers versus those of us not in that realm. So that's frustrating because I would love, you know, to have a system where, you know, we could log in, see where those referrals are today, you know, see where someone is at, you know, and double check what services they got. I mean, even amongst our partners, right? Sometimes people are getting duplicative services. St. Vincent de Paul maybe gave them some money. We gave them some money. Now they're going to Dove House saying they don't have any money. So yeah, it'd be nice, you know, especially with this, what I consider a smaller community like this in the county, to be able to, you know, track some of those things in some way, shape, or form. And there are some good products out there, but legal privacy.
I know what you're talking about. This HIPAA issue is something that John and I have been talking about, and I'm just putting it down as one of the bullet points that we need, whatever it is that we need to think through. Mel, go ahead.
It's not HIPAA as much as the substance use disorder federal regulations around 42 CFR Part 2. And that has been a challenge. And we have been trying to get a health information exchange or a community information exchange going for a region, but there have been concerns, especially around that substance use disorder. So what I can tell you too is we're looking at, can we bring in someone maybe from the national level to talk across our region about what is for, you know, what do you have to do so that we all are using the same language, because it seems people are more risk adverse or have different understandings about what is okay and what isn't. So there's part of that. And then what I could tell you, and it feels really backwards in this time, but in Clallam, we started a project, and you've probably heard about it a ton, some of you, with Known and the Port Angeles Fire Department. We're calling it Clallam Care Connection. And, oh, sorry, I still have my video off. I live in the country, I have terrible data, so I have to always protect it, I'm sorry. But what they're doing is we've started a little care connection, and we're still using paper referrals and business agreements. So it's kind of old school, but they're actually coming together now that we're just looking at adding on Peninsula Behavioral Health and Rediscovery, which works, they're the social workers that are hired by the police. So we're trying to find workarounds until we can get to that community information or healthcare information exchange. If you want to know more about that, I'd be glad to share at some other time. And it does feel wonky and it is frustrating, Cherish, I agree, because we just want to help people and be efficient with that. Well, so, and something I heard from larger communities that you might not have to deal with as much, but in other places, they don't even know where the navigators are. So some people will get assigned to 4 navigators and others will be assigned to none. And so then you have that issue of who's helping them through the process.
Thank you, Mel. I know we'll circle back around to you. I really appreciate you bringing that Clallam Care Connections program forward. That's of interest. And then Ford, you were about to say something?
Yeah, you know, when I intake someone at Safe Harbor or when DVH does, and I believe Believe in Recovery does this too. We screen for all their needs when they come through the door, and we make appropriate referrals based on what their needs are. If they need housing, we send them to OLICAP, and if their financial needs, we try to hook them up with the different places that they can obtain some funding and stuff like that. The difficulty arises for me is I can give you a bulk number, but I can't give you individual names and stuff. So that's where we run into a problem. Unless I have a release of information, I can't even tell the referral source that a person has showed up at my agency. So the doctors think that substance abuse treatment is a black hole and people aren't getting anything done. But that's not true. They are. They just refuse to let us talk to their doctor. So, you know, there's got to be some kind of release of information between the two agencies. If they get it at the hospital and fax it to us, then we can reply to them. But if we have nothing and they refuse to sign it, I can't give you any information. You know.
So for this particular topic, I'm some things that I'm noting. Thank you, Ford. That's a good. There's this systemic thing that Ford has talked about. How do we make sure that if we got a release at one place, it gets sent around and it's understood that it's meant for this realm of providers. There's the checking back with Mel on the Clallam Care Connections and addressing some of that issue that Cherish is talking about how can we talk to each other while observing the proper privacy issues. And then working with the emergency department to look both at referrals, what referrals and then where they were taken to. And then working with OLICAP on what info do we need and then what do they have and where could they get whatever it is that is in between what we have and what we need. So those are the action items. Did I miss anything? Okay, so I'm going to hop now to what else we would be using the this data for. And I wanted to give a chance for Peggy Webster, who's from the Affordable Housing Task Force, I know that for one thing, the fact that we have this group together it's very useful for behavioral health. And we also know that there's sort of this continuum that goes to housing. And I think that that's something of what that the working age group in CHIP might well end up looking at. And I thought it made sense because this group is already together and looking at data to have Peggy come here and give us a sense of what you need as you're going after grants, because we know that housing is part of the behavioral health challenge. So I'm going to turn it over to Peggy.
Thanks. Well, this conversation's been very interesting so far, and I think there might be real benefit with deeper conversation with Cherish at OLIC. So for example, we're looking at a project where we think we might try to go for CDBG funds, which are federal funds funneled through the state. But if we had better data on how many of these folks that you all deal with are veterans, because I can go for a pot of money that's for veterans. And there are other types of categories of things that would help us get pots of federal and state money to create the housing. So that was just one that jumped out at me as you all were talking. There are others that how many are disabled, and you know there's a pretty broad definition of disabled, but how many are disabled? How many are veterans? What's the age? If certain age groups there are pots of money for. Domestic violence survivors. What else? Employment status. Are they employed or not? And of course, the income bands. You know, are they basically have no income, or are they at what percentage? And as we all well know, substance abuse and behavioral issues aren't at all limited to lower income. They go all the way up. So right. There are certain pots of money that we can go for the folks that are 100% area median income. But you know, would be very helpful to have data on what our population is, what our need is. And then we could start to line up the resources for the housing.
So I heard you say, it sounds like a conversation with Cherish might be one place to start. Is there anything else that you can think of after having this conversation that might be a good starting point?
Yeah, I don't know, exactly where Cherish comes in the thing, and in terms of like the emergency responders and all of that, I don't know how that connects with the folks who end up at OLICAP, but that group of people, it would be really helpful to know more about that person. And
at the hospital, does the hospital ask if they're veteran or disabled when they come into the emergency room? Does anybody know?
Yeah, I think we do.
So we might be able to get data that way.
Right, but I think it would be very helpful to get that data into the hands of folks who are out there scratching for money wherever we can find it.
Yeah, I mean, that is generally, we collect all that type of demographic, data for purposes of, what incomes, individuals can, potentially, receive. So any of the veteran, disability, domestic violence, how many children, income band, all of those things are part of our general intake. Regardless.
So if we had, kind of yours plus whatever the hospital collects, we can get to see the whole picture. I just learned the other day that, or yesterday, that the state has 811 vouchers that they're kind of pretty easy to get. All you got to do is go say, hey, give me a voucher, and they'll give it to you. As long as you got a group of disabled people and you've got somewhere to put them in housing, you got a way to operate it. So
it's the housing that's the issue, but yeah, we have some potential 811 for the 7th and Hendricks project.
Right. So we could, but once you know that you've got that operating, then you can start to put together the other pieces.
So I should ask the hospital, is it reasonable to think we could pull that data out from the emergency room data or emergency department data?
Veteran status?
Veteran, disabled, employment, I don't know, do you collect income base?
So income, the only thing I've gotten that's touched on that is people who have an approved, what's the word? Like a low income application where they receive a sliding scale charity amount. Yeah. So I think that's the only, and then, if they're on Medicaid.
Medicaid would tell you, yeah.
Medicaid. Okay, so Medicaid, disability, that's collected at the emergency department. Is it?
I haven't specifically gotten disability yes or no kind of stuff yet. I would like to figure that out. But
okay, so we can talk more about this, but there might be some possibility with the emergency department that we could look at. So you at least understand why we're trying to get it and what we're trying to get, right, Adam?
Mm-hmm.
Yeah. Okay. All right. So that's the beginning of a conversation there. So I think we've covered most all of the topics. We're at 2:55. I will do up sort of an action list and then start working with, who we've got to get with to get one little piece going next. And maybe it might well be into January that we come back around together. But I think little subgroups will make progress in between times. Is there anything anybody else wanted to say as you listen to this conversation? You're excited about data, you're fed up with data.
Wouldn't it be convenient if everybody had a license plate on their shirt and you can just run their plate for mental health counters?
Very handy. Jolene, I appreciate that you were able to come here, and I know that you see a lot. Is there anything that you've heard here that you'd like us to think about or redirect on?
Not that I can think of.
Okay, well, I'm really glad you could be here. Okay, anyone
Happy to
else?
be here.
Anyone else? Okay, go forth. Have a great rest of the afternoon. Thank you so much for your time.
Thanks, everybody. Appreciate it.
Bye-bye.
Take care, everyone. Bye-bye.
Bye.
Okay.